Yeah, the light behind me is kind of bright. But hi, my name is Tammy Vincent. I'm the president of the Chicago branch of the American Federation of Teachers Black Caucus. I working with a group of like-minded people who came together when we noticed that since 2019 and when the COVID lockdowns began, that we saw an increase in suicide amongst Black youth. There was also documented um, stressors, related to poverty, or related to violence, related to just the stress of the COVID vaccine and the requisite trauma of racism. So, in the
So in
midst
the
of
midst
that
of that,
COVID lockdown, we had the murder of George Floyd, and there were prolonged protests against his murder. So the country was in an upheaval, and it spread internationally. What wasn't fully tracked was how all of this was impacting people's emotional and mental health. So again, we went back into the classrooms, maybe prematurely, without fully assessing what our students had encountered, what the educators had encountered, or what the staff within our school settings had encountered. And if we know that, our schools are a microcosm of our communities. So if we're having behaviors that are tied to trauma or stress in our classrooms, we know that it's also impacting our communities. So there, a lot was going on. We had within the Black Caucus, Dr. Wright, who had offered us some solace as educators, and we were luckily we were connected with Ashanti, who brought us all together to host the series of forums. This is the fourth of a series. This one is titled "Recognizing the Signs of Suicide." And coincidentally, today when I got to school, I'm still teaching fifth and sixth grade science to at an elementary school in Chicago, and some of my coworkers were talking in the hallway, and one of the teachers says that lots of students are coming to her saying that they're feeling suicidal. So her take, on it was concern for the students' mental health, but it was also concern for the safety of our school community, because her thought was that if these children are not feeling safe, if they're feeling the pressure of, and their thought is, my only recourse is to kill myself, that too we think can manifest in other ways. So, and Dr. I'm sorry, introduce who's here, but I'm sure he has more information. But I'm wondering if there's a correlation between, the stressors that lead people to consider suicide, also consider folks, cause people to consider hurting others. So again, safety and wellness is a huge deal in our schools, and it's a bigger deal within our communities. But we're, a smaller setting, so we do want everyone there to be safe. We also want everyone there to be considerate of what people are bringing into our settings. So we need to recognize the signs of suicide. We need to recognize the signs of trauma, and we need to try to help people deal with it and try to get to the other side. So again, our presentation today will be with Dr. Daniel Holler and Dr. Daniel from Bethune-Cookman. So we appreciate your being here with us. There will be a presentation, and after the presentation, we'll take some questions. So as soon as Dr. Holler is ready to begin his presentation, we're good to go. So thank you everyone for being here. Thanks.
all right, thank you for that, Tammy. I'm ready if you all are. And so I guess we can go ahead and get started. I think you're recording, Ashanti, is that correct? It's recording. Okay. All right.
Yes, we're
So
recording.
Just a brief introduction. First of all, thank you all for inviting me here to speak to you all today and taking the time out of your day for this. So my name is Daniel Holler. I have a PhD in clinical psychology from Florida State University. And that is where I studied under Dr. Thomas E. Joyner Jr., who is a preeminent psychologist when it comes to suicide research assessment. And so Dr. Joyner is probably one of the most published psychologists in the realm of suicide research and risk assessment and reduction. And so that is also my area of expertise. I tend to focus more on individuals of African descent or African Americans. And so that's what my presentation today will be mainly tailored to. But of course, these things will, of course, also apply to the population in general. I'll talk about suicide in general, and then also talk about some of the unique factors related to Black mental health. Some other things, I currently serve as the Assistant Dean for the College of Nursing and Health Sciences at Bethune-Cookman University. Bethune-Cookman University is a small private, historically Black college/university in Daytona Beach, Florida. And I also serve as the chair for the Department of Psychology. I do research on suicide risk assessment among individuals of African descent, as well as suicide among law enforcement officers. That's actually how I got this connection to the city of Chicago. I was going up to Chicago for a number of years, doing trainings and workshops with police officers. I did a 2-day training at Chicago PD headquarters on suicide risk assessment among police officers, general mental health and well-being among police officers. Also, we looked at financial matters related to officers, because that's also associated with their job performance and mental well-being. And that's how I kind of met Ashanti at one of those workshops that I was giving. And I've been working with her pretty much at least once a year. We've been getting together to do some work to try to, improve the mental well-being of the citizens of Chicago and the surrounding area. And so that's pretty much the gist of it as far as who I am. And so without further ado, I'll go ahead and get started today. And of course, if you have questions, you can put them in the chat, and I'll either try to answer them while we're presenting or at the end.
And Dr. Holler, if I could for just a second, and
Sure.
And you'll go first. And I was remiss in not introducing Dr. John Levy, who will also be presenting today as well. Same topic. So thank you so much.
All right. Okay, so let's get started. So today I'm going to be talking about the role of trauma and violence in suicide, and we'll be learning how to recognize some of the signs that some of our students may exhibit, or people in the general population may exhibit. So like I said, my expertise, I tend to focus on Black mental health matters. And so that's kind of what this presentation is going to be tailored to. So while I'm presenting, I want you to think about how this applies to you and your community as well. And I'm glad to answer any questions as we go along. So Black mental health matters. Without mental health, we cannot be healthy. So any part of the brain can become ill, just like you can get, you're going to have heart problems, you can have problems with your kidneys, liver disease. The brain can also get sick. And when the brain gets sick, we call that a mental health condition or a mental illness. And mental health conditions are difficult for us because they make it hard for us to relate to others, for us to perform at our job well, and to feel that we have a general sense of well-being about our lives and how we feel about ourselves. With proper treatment, though, we can get well, we can start to function better in the community and in our lives and in the relationships we have with others. But without that treatment, things will get worse. It won't just go away. There is no cure for mental illness. It's a chronic illness. And so you will have to be under treatment, either by taking medication or being involved in therapy periodically throughout your life in order to maintain your wellness. So some important terms I want to talk about briefly because it's important for us to have a similar understanding about these terms that I'm going to use. So violence is going to refer to any type of act that causes harm to others. Trauma is the body's response to violence or to situations where your life has been endangered. Okay. Stress is the body's the way the body deals with problems that we face in society as we try to solve them. You know, can cause us to feel tense and a little irritable. These are signs of stress. Acculturative stress is the pressure or the irritability sometimes that comes when we try to, as minority group members or individuals of African descent, try to decide how we are going to integrate into the larger society and which values we're going to take from our community and which values we will leave from our community and which values we will accept from the dominant society or which values we will leave from the dominant society. So that push and pull from being a minority group member and trying to integrate into the larger society can many times cause acculturative stress. And suicide is a term that we're using to define whenever someone willfully attempts to take their own life. So I like to start off with this quote from Dr. Bobby Wright. Dr. Bobby Wright is a Black psychologist. I believe he was up in the Chicago area for a number of years before he passed. But Dr. Bobby Wright coined the term menticide. And menticide is the deliberate and systematic destruction of a person's or group's mind. And he said that this may give a clue to why the Black race, after developing such an advanced civilization for the last 400 or so years, has been assisting in its own destruction and nearly total subjugation of Africa by foreign invaders. Okay. And so this idea of menticide, I want to kind of delve into and how this relates to the current state of Black America and our mental well-being. So whenever we do clinical assessments, it's very important to get a history of a person, because without the history, we can't assess them properly or diagnose them or come up with treatment. And so when we look at the Black community, we can't just look at the Black community out of the context of history, right? And so in the context of history, Black Americans were brought here on the transatlantic slave trade, right? Back in 1619, when the first Africans were brought in as slaves to America or to the West, we called or coined this term the Ma'afa. The Ma'afa is a Kiswahili term that means terrible occurrence or great disaster. It's also known as the Black Holocaust, right? And millions of Africans died during the Middle Passage and transatlantic slave trade. And then once they got to the shores of the West, you know, before it became the country that we love today, of course, there was chattel slavery that was involved. There were years of violence inflicted on these Africans brought to America. And eventually there was a period where we were emancipated. Our ancestors were emancipated and set free. Right. But there was no treatment given for all the years of violence and dehumanization that these people faced. And so we're going to talk about how, you know, it's important to address your history of trauma if you're actually going to be well. And if you don't address that history of trauma, you may actually perpetuate some maladaptive behaviors and teach those things to your children and pass them down throughout generations. So another important figure is Dr. Joy DeGruy. Dr. Joy DeGruy coined a term called post-traumatic slave syndrome. So post-traumatic slave syndrome is a set of behaviors, beliefs, and actions related to multi-generational trauma, as well as undiagnosed and untreated post-traumatic stress disorder in enslaved Africans and their descendants. So slavery followed a systemic and structural racism. Systems of oppression have resulted in multi-generational maladaptive behaviors. which originated as survival strategies, right? So what are we talking about here? What we're saying is that during the trauma, the African Holocaust of slavery, of chattel slavery, the transatlantic slave trade, Africans had to adapt certain behaviors and lifestyles and cultural changes in order to survive here in the West. And sometimes those behaviors that they adapted in order to survive became maladaptive once they were emancipated and set free. But these behaviors, which are no longer beneficial to a group of people, are still practiced. And so they actually may be a detriment to that group of people. So post-traumatic slave syndrome continues because children are often indoctrinated by parents and society into the same maladaptive behaviors long after those behaviors have lost their contextual effectiveness. So if we think about Albert Bandura and social learning theory, right, we know that children learn by observation. So you don't even have to tell children anything. You just do something and they learn by what you do more so than what you say, right? And so Dr. Joy DeGruy gives a great example of how there are maladaptive behaviors that are passed down throughout generation, and it becomes what people think part of the culture, but it's not really part of the culture. It's not Black culture. It is and a maladaptive way of surviving that used to be adaptive under the conditions of slavery, but no longer are. For example, she gives this example about a family during Thanksgiving, right? And there's an African-American family. A little girl is watching her mother, make a roast. And so the little girl watches her mother make a roast for the holiday. They're pretty affluent family, well-to-do, got a lot of people over at the house. And the daughter watches the mother cut a quarter off the front and a quarter off the end of the roast. And so the daughter asks the mother, why did you cut a quarter off the front end and a quarter off the back end of the roast? And the mother says, well, I don't know. That's the way my mom did it. Why don't you go ask your grandmother? So the little girl goes and asks her grandmother. And the grandmother tells her, yes, that's a good question. I don't know. That's the way my mother used to do it. So you'll have to ask your great grandmother. So the little girl was fortunate enough that her great grandmother was alive, and she went to ask her great grandmother, why do we cut a quarter off the front and a quarter off the end of the roast? And so the great grandmother told her that, well, when I was a child, we were very poor. And so we only had one pot to cook our roast in, and we had to use it to cook everything. And so if the roast was too big, we had to cut the roast down to size to fit in the pot. And so the daughter said, oh, okay. And so now she understood that this cutting of the roast and putting it into this small pot so it would fit is a result of the impoverished conditions that her family came out of. And it's just been passed on down the line without anyone asking, why are we doing this? So much so that to the point now where the family is affluent and able to afford, bigger pots, and they do have bigger pots to put their roast in, they're still cutting a quarter off to put it in the pot because that is the family's culture that has been passed down. But no one ever asked a question about why we actually do that, to see that it was an adaptive way to deal with poverty at the time. But today, when they have this affluence, it may be maladaptive because there's no need to cut the roast because you have the ability to afford to buy bigger pots, right? So that's kind of a simple way to explain or give an example of how things are passed down and taught by observation and may have been adaptive at one point in time, but are no longer adaptive for individuals today, and actually may be maladaptive behaviors. It may be to their detriment to be still practicing those past behaviors. So post-traumatic slavery syndrome cannot solely be treated and remedied clinically. It requires profound social change in individuals and institutions. Another area of importance that we need to discuss is the role of violence in our community. And all this is going to lead up to my discussion on suicide. So Dr. Larry Richardson, he's a psychologist, one of my mentors in Jacksonville, Florida. He was the psychologist or therapist for the Jacksonville Jaguars for a number of years before he retired. This information comes from his work. Violence is the #1 killer of Black children between the ages of 15 to 24. So there's a prevalence of violence in our community, right? Racism, social isolation, drug and alcohol abuse, and media violence contribute to violent behavior. African-American youth often suffer from Black self-hatred due to conditioning from their social environment. So why is violence prevalent in Black communities typically? Well, it's not associated with their Blackness. Violence is associated with poverty. And unfortunately, because of the history of the Ma'afa and slavery, chattel slavery in America, Black individual and systemic racism, Black individuals tend to live in impoverished environments. And those impoverished environments are what is correlated with violence. Victimization levels increase as youth get older. Youth ages 12 to 24 suffer more violent crimes than any other age group. Over the lifetime, 71% of 14 to 17-year-olds have suffered an assault or will suffer an assault. 28% will suffer some type of sexual victimization, 32% abuse or neglect, and 53% some type of property victimization like a robbery. Black youth are 3 times more likely to be victims of reported child abuse or neglect. Black youth are 3 times more likely to be victims of robbery, 5 times more likely to be victims of homicide. Living in urban areas increases the risk of exposure to violence. 25% have witnessed a murder, right? So this sounds like, this is like almost unfathomable about the amount of violence that Black children are exposed to. This idea about 25% have witnessed a murder, or 18% have seen a dead body outside. That reminds me of this movie back in the day called Boys in the Hood, and one of the opening scenes, the young kids, they're probably like elementary school age or middle school age, are walking in the neighborhood in South Central Los Angeles, and one of the kids goes, "Hey, do you want to see a dead body?" I remember I was probably about 12 or 13 at the time, and I thought that sounds very weird. I don't remember anyone ever talking about seeing dead bodies as a child, but as an adult, now that I understand the research, I understand that that was an actual true occurrence, that those things do happen. Young people do sometimes see dead bodies in impoverished environment. A study of 7-year-olds reported that 75% have heard gunshots, 60% saw drug deals, 10% have witnessed a stabbing at home. So what is this effect of trauma and violence and this history that African Americans share here in the West, right? How do these things affect the mental health conditions of African Americans? Well, the most common mental health disorders among African Americans include major depression, attention deficit hyperactivity disorder, post-traumatic stress disorder, and suicide. So major depression is the most common mental illness diagnosed in the world. And so, of course, this is also going to be the most prevalent diagnosis among African Americans as well. And just like we find it to be higher in white women, it's also higher or more prevalent in Black women, right? It's higher in women in general. Attention deficit hyperactivity disorder, or ADHD, is often overdiagnosed or misdiagnosed in Black children. And so there's a high rate of ADHD diagnosis in the Black community that researchers are trying to, weed through and figure out better ways to assess and diagnose. Post-traumatic stress disorder, of course, we know that's going to be common because I just talked about all the violence that occurs in impoverished environments where African Americans tend to congregate and live, right? And then we have suicide. Suicide among African American men, boys and young men, is actually increasing at a higher rate than any other racial ethnic demographic. And that may be surprising to many because oftentimes in the Black community, people say, oh, Black people don't die by suicide. We don't commit suicide. I remember as a grad student, people used to ask me, why are you studying suicide? Black people don't die by suicide. And at the time, when I was first starting to do the research, I was like, oh yeah, well, that's probably true. I held similar beliefs until I got deep into the work. And then I started to see that that's actually not true. At the time that I was first started doing this research, I'd say back in 2003, it was reported that suicide among African Americans had increased by over 300%, particularly in African American males ages 14 to about 25. Okay. So again, this is something that we don't typically think of in the Black community, but it is something that is a serious problem that needs to be addressed. Typically, when we think about suicide, we think about white males age 65 and older who are retired, divorced, or living alone. But actually today, what we're seeing is that young Black boys are dying at suicide at a higher rate than anyone else. And the rate keeps increasing every year. So what is the role of racism in Black mental health? Okay, we talked about the Ma'afa, we talked about the trauma of the slave trade and chattel slavery, right? Well, there are also systemic structures of racism that have been in this country since its foundation, right? Because slavery was here before the United States was formed, right? And so there are institutions and rules, laws, and policies, practices that have been in place since before America was founded. And so those institutions and the racism that is involved in those structured institutions also have a role to play in Black mental health. So the University of California, Los Angeles did a study that was published in the Journal of Pediatrics in November of 2021, and they indicated that discrimination makes you more likely to develop mental and behavioral problems based on their research. They looked at medical records of over 1,800 Americans ages 18 to 28 years old, and they cited race as a common factor for discrimination when they were reporting issues related to stress and depression. Those who had frequent discrimination were 25% more likely to be diagnosed with a mental illness, and they were twice as likely to develop severe psychological distress. People of color or minorities or, any of those euphemisms that they use to describe Blacks and Hispanics or minority group members, people of color are more likely to be exposed to negative socioeconomic factors such as poverty, unemployment, incarceration, or abuse. And African-American adults are 20% more likely to report serious psychological distress, more so than white adults. Native or Indigenous Americans have the highest reported rate of mental illness. Racism causes Black Americans' brains to age faster than people of other races, increasing the risk for dementia. This was actually just published in the Journal of the American Medical Association Neurology, I think in November of 2022, so just last month. So we see that racism is being studied and its impact on the Black community or minority group members' health, and they're seeing that there is an effect, the harmful effect of racism. So racism can be looked at as a type of social violence against minority group members. So going back to Dr. Richardson, this is based off of some of his work where he looked at different types of behavioral styles that people have. So our behavior, what we do, our culture is largely behavior is largely determined by our culture. And so there are 4 types of behavioral patterns that people can practice. They can have an authentic behavior, which is consistent with and predictable from their cultural substance, their ethnicity, their cultural background, right? They can have an adaptive or adapted behavior, which is consistent with the culture and has been modified in response to the environment. So that would be like acculturation, right? So you practice your cultural beliefs, but you also have to modify how you practice your culture because of the environment that you live in, if you're a minority group member in the dominant society. There's also the adopted behavior. That's when someone uncritically borrows from another culture. We can think of that as assimilation, right? And from Dr. Richardson's work, he said that's highly correlated with having self-defeating or self-hate type beliefs. And then we have aberrant behavior. Aberrant behavior is antithetical to the culture, and if not corrected, it will result in a distortion and or destruction of an individual in their cultural group. So this is like being culturally misoriented. That would be self-destructive, right? So cultural misorientation is a term that is defined by Dr. Kobe Cambone from Florida A&M University, where an individual of African descent is not oriented to their own cultural values and beliefs and the vested interests of their community. They are miseducated and are only they only ascribe to those cultural value systems of the dominant society. And we can see how that might be problematic for individuals of African descent, given the history in the country. When I talked about the Ma'afa, the founding of the country before slavery, chattel slavery during the country, Jim Crow laws, and a lot of the negative stereotypical beliefs that are held about African Americans or Black people, particularly in the United States, right? If you are uncritically absorbing thoughts, values, and beliefs from the dominant society, and you don't have any type of cultural understanding or African-centered view, you will adopt or assimilate racist beliefs about your own community, right? And we could understand how that's self-destructive to the individual and to the community that they are involved in. So how do these things relate to suicide? Well, I'm going to show how, we talked about the Ma'afa being brought to the West as slaves, and how that creates a sense of individuals not fitting into the society, like they don't belong. We talked about how there is structural racism in the society, negative beliefs and stereotypes about Blacks that make Black people feel ineffective or like they do not contribute to society. And we also talked about violence, right? The violence that people who live in impoverished environments are often exposed to creates trauma. And it's those three factors that I'm going to expound upon in a moment to show you how those three factors intertwine to put a person at risk for suicide. So this is from June 2021. This is a study that was published in the Journal of American Medical Association. And it said that temporal trends in suicidal ideation and attempts among U.S. adolescents by sex, race, and ethnicity from 1991 to 2019 showed that while rates of suicide ideation and anxiety have risen sharply during the pandemic, COVID-19, a new study found that suicide attempts, particularly among adolescents, have been rising at an alarming rate long before COVID-19. If you remember, I told you suicide rates were increasing, particularly among young Black men, because I started doing this research back in 2003. So in their study, let's look at this chart. In their study, they looked at the trends of suicide ideation and suicide attempts by race. So here we have suicide ideation, and we have different racial ethnic groups. Okay, and B is suicide attempts. Generally, if we look at the trends, we see that suicide ideation for most groups were decreasing, right? So for Hispanics, for Blacks, for whites, okay, for Asian Pacific Islanders, right? However, for Indigenous Native Americans, suicide ideation just steadily increased. They have the highest suicide ideation rate, suicide attempts, and completion rates than any other racial ethnic group. It's often not talked about because there's such a small percentage of the population. And of course, if you know, the people most likely to study problems in a community are the people from that community. So it is something that is known, but it is not something that often gets a lot of research and is talked about, nor is suicide among individuals of African descent. Because like I said, mainly the people who we looked at as risk for suicide were those who are white males age 65 and older. They're more likely to die by suicide, and white females, though, are more likely to attempt suicide, though they're not as likely to die because they use less lethal means. Now, when we look at attempts, we see that from 1991 to 2019, those rates have been decreasing for all these groups. So even for American Indians or Native Americans, their suicide attempt rate has been going down. We see Hispanics, the rate has gone down. We see for Asian Pacific Islanders, the rates have gone down, and we see for whites. But if you notice, there's one group that is having this interaction effect here that's actually been increasing, and that group is African Americans or Black people. So for some reason, suicide attempts have been decreasing for other groups, but steadily increasing for African Americans, according to the study that was just published. So teenagers are attempting suicide. Teenagers attempting suicide has increased by 22%, according to the study. There was more white women attempting suicide from 2009 to 2019, right? And Black males had the highest increase of suicide attempts, increasing nearly 80% between 2009 and 2019. So again, we still see this steady increase of suicide among individuals of African descent, particularly males, though the rate is not as, hasn't increased as much as when I first started studying it. It is still the highest group when it comes to suicide attempts and deaths. So why is it that people die by suicide? Well, according to Dr. Thomas Joyner, his interpersonal psychological theory of serious suicidal behavior, he said it's related to these three factors in this Venn diagram. So we have the thwarted belongingness, right? Feeling that I am alone, like I don't fit in to the society, to the mainstream, right? We have perceived burdensomeness, so feeling that I'm a burden, I'm ineffective at what I do, so much so that people would be better off without me, right? If you can't get a job and provide for your family, if you're looking on social media or in the news and all you see is negative images about you or your community, right? Let's say if you're a Black male in this in America, you may feel like a burden, right? Given that it seems like society is almost targeting or against African American men. And then we have this capability for suicide, right? So first off, you have the thwarted belongingness and the perceived burdensomeness. And when you have those two, that creates the desire or the ideation for suicide, wanting to die, right? So a lot of people may have the desire to die, but not everyone goes on to attempt or complete suicide. The thing that makes someone, if you want to say that, you know, for lack of a better expression, pushes them over the edge, is this idea of the capability or the acquired capability for suicide, the acquired capability to self-injure, right? Not being afraid to die. This acquired capability comes from repeated exposure to pain, trauma, and violence. And so hopefully you can see how these factors relate in the Black community in particular. These are in general for everyone. But again, like I said, I want us to focus on individuals of African descent because that's one of the groups where we're seeing one of the greatest increases. So I'm going to show you a little video, just a couple of minutes, maybe 4 minutes of Dr. Joyner speaking on the Dr. Phil show about this theory. Again, remember, he is the preeminent psychologist on suicide.
Now joining us at this point is Dr. Thomas Joyner, a distinguished research professor in the Department of Psychology at Florida State University. Now, he's written a book called Why People Die by Suicide. Let me say that again, and there's a picture of it up. Why People Die by Suicide. It's not a beach read, I understand, but it is an important, important message. Now, sadly, Dr. Joyner's own father committed suicide 18 years ago. Now, this really moved you to try to figure out how somebody with such a great and productive mind could get in such a dark place as to end their life.
That's right. My dad's death makes me feel honor bound to not only understand it, but to exact some revenge for it. Something or somebody stole my dad away from me is the way I view it. And so I feel honor bound to return that favor and exact revenge. Here it's going to be exacting revenge on suicide itself by studying it scientifically, by advocacy, and through clinical and prevention work.
Yeah, and so by helping people understand it, know the warning signs, see what's going on, then we're raising awareness just by having this conversation.
Absolutely.
And that's exactly what these wonderful people are doing down here, because at this point you say that Casey really wanted to make a difference in this world, and you can't just now sit back and not do something given the experience, true?
Yeah, exactly.
I had a lot of the same pain that I think Mr. and Mrs. Brooks expressed, and that pain was strong for a while, but it did lessen. And then after it did, I poured my professional energies into trying to combat this international killer.
And you've made some headway. You figured something out. Dr. Joyner believes that people considering suicide share three traits in a very common way. And the first one is feeling like a burden on other people and that their death will be worth more than their life. Talk about that.
That's right. It's the idea, the mental calculation that my death will be worth more than my life. If you truly believe that, you could see how that would facilitate suicidal behavior. And we've shown in multiple studies that it does indeed do that. Crucially, the person is mistaken in that perception. But the trick is that they don't know that they're mistaken in that perception. They believe it to be true, and it spurs suicidal behavior.
And isn't it true that most suicidal situations and dilemmas that push people over the edge are transient? That if they had just stuck it out, they tend to get better?
Absolutely. There's no question about that. And there's also no question, as you've already alluded to, that there are good, effective treatments that work for the conditions that underlie suicidal behavior.
Yeah. Psychologically, therapeutically, pharmacologically, there are so many things that can give people relief.
Absolutely.
The second common trait that Dr. Joyner talks about is a feeling of loneliness or social disconnection.
If you look through the literature, the scientific literature on suicidal behavior, arguably the single most powerful risk factor of all is loneliness, a feeling of alienation from others.
Yeah, so they just don't feel like they fit, belong, so they're just on the outside looking in, so why not just leave?
That's right.
All right, and the third thing is an interesting thing that he talks about called fearlessness. Regarding pain, injury, and death. People considering suicide have learned to overcome these natural fears, and you say that that's more common than cowardice or that sort of thing.
That's right. I think it's a common misunderstanding to think of people who have died by suicide as cowardly or weak. That's just not accurate. And indeed, to do something as fearsome and as daunting as death by suicide, you do require a kind of fearlessness in order to carry through.
Yeah. When we come back.
Okay. So I see that, you know, I don't want to monopolize all the time, but let me hit some highlights for you. I think I covered this thwarted belongingness. Again, that's one of the main factors, perceived burdensomeness, and I explained how it relates to the Black community and how it relates to the community in general. And this important factor, which is this acquired capability. So people who have high incidence of exposure to violence and trauma in their history, those are the individuals that we need to be keeping our eyes on. Okay. So before I leave you all and let our next presenter come up, I just want to talk about some solutions. I tend to be very solution focused, right? So faith, spirituality, and community are important. There's research that shows that people who practice some type of religious or spiritual belief system, that it improves their mental well-being. There's a book that I published that looks at suicide and eating disorder behavior among individuals of African descent. And what I found in that study, was that African self-fortification, which is self-knowledge and self-affirmation related to Afrocentric values, customs, and institutions, consciousness about one's cultural heritage, attitudes and beliefs about one's race, serve as coping mechanisms which buffer against many forms of psychological distress. And so individuals who were high in a culture distress but low in African self-fortification had a higher suicidality risk than those individuals who were high on African self-fortification. So African self-fortification was actually a buffer against suicide ideation and attempt for individuals who were undergoing a culture distress. And as a side note, for Black women who they do die by suicide, but they are the least likely racial, ethnic, and gender group to die by suicide. But what I found unique among individuals of African descent who are women, those who have high cultural distress and low African self-fortification were at greater image for body image dissatisfaction. And body image dissatisfaction is related to eating disordered behavior, and people who have eating disorders have a high death rate by suicide. So what are some solutions? I would say some options on how to increase African self-fortification and racial self-esteem through teaching culture and history from an African-centered perspective, where we see ourselves as the victor or hero instead of from a Eurocentric perspective, where we are typically painted as the victim or villain, right? And that would lead to greater unity, positive communications between Blacks, and hopefully less violence as well. So 6 options on how to implement this, how to increase belongingness, effectiveness, and decrease exposure to trauma and violence. Well, 1, sending children to African-centered schools or after-school programs or Saturday schools would be recommended. Teaching them African history at home from individuals like John Henrik Clarke, Ivan Van Sertima, Cheikh Anta Diop. Also scholarly works from individuals like Dr. Amos Wilson, Dr. Naeem Akbar, and Kobe Cambone, who I mentioned earlier, who actually came up with the African self-fortification scale. Practicing a traditional African cultural religion or spiritual system. Like I said, religiosity is associated with mental well-being. Participating in some type of rites of passage program or African-centered fraternal organization or society. Like these things, when you participate in your culture, will make you feel like you belong. They may make you feel more effective and that you are needed in your community, right? And I think something that's most important, no matter what's going on, you have to learn how to view the world and all its problems and possible solutions from your own group's vested interest and cultural perspective. So whenever you're learning something in class and in the schools for students, they should be looking at, well, how does this apply to me as an individual and to the community that I belong to? Of course, there's help out there. And so we have the National Suicide Prevention Hotline. It's 1-800-273-TALK or 8255. They've also created a 3-digit number like 911. Instead of dialing 911, you dial 988. And I would recommend that you get a culturally competent psychologist if you're an individual of African descent. And for that, you could reach out to the Association of Black Psychologists. Their number is 301-449-3082, and they will help you find an African-American psychologist in your area. Okay, and so I'd just like to thank Ashanti and the Chicago School Network for inviting me to talk, and the creator for our individual differences and collective strengths. And so if there are any questions, I'll take them, and if not, we will, pass it on to our next presenter. Thank you. So any questions or comments? All right, Tammy, it's back to you.
Okay. All right. Thank you, Dr. Holler.
Well, if I could just unmute for 1 second, excuse me, Tammy.
Absolutely.
This is Dr. Loretta Wright. Just want to thank Dr. Holler so very much for all this valuable information and a great presentation.
I appreciate that. Thank you. I wish I had some more time. It would take it a little slower.
Oh, yeah, it was awesome information. And thank you so much for agreeing to share your information with us so we can share with others, because it was extremely valuable. And
Mhm.
if you don't mind, you'll be able to stay until the end. So if
Yes,
Dr.
I'll be
Levy
here.
Dr. Levy can begin with the presentation, and we'll take questions for both you guys at the end. Well, I'm sorry, for both at the end. Apologies, I misspoke.
Okay.
And so, Dr. Levy. Sorry, I'm reading the chat. Okay. Oh, I'm sorry. Dr. Levy, are you prepared to begin your presentation?
Yes,
Or-
yes, I am.
Okay, thank you.
Sorry, I didn't hear you for a second there. That's my bad. I'll try to point. Hey everyone, my name is Dr. Levi. I just go by Levi though. I guess if you saw me in a clinical setting, you could call me Dr. Levi if you wanted to, but I normally just go by Levi. So a little bit about me. I grew up in North Carolina, where I spent most of my time. I went to med school there and then got into an anesthesiology training program here in Chicago. I was really interested in training in a larger city with a more diverse patient population. And so Chicago seemed like a great fit. So here I am. The reason that I was interested in this conversation and being a part of this chat is because two things. One, I'm also a part of, as a resident with the University of Illinois, I'm a part of our residency union, and we were trying to get more involved with unions in the area. So we wanted to try to reach out and be involved with more events with the teachers union. So that was one of the reasons. And then second was because PTSD and trauma and suicide is a very important issue for me. At the end of my, I guess, fourth year of medical school, I was actually diagnosed with PTSD. And so I had to figure out a lot of tools and things to deal with those symptoms, since there was a lot that happened during COVID, and there's a lot of things that changed, and I don't know, there's also just like a lot of things that happen in the hospital that could be very stressful and traumatizing, from seeing a lot of gun violence to even seeing things that remind you of things that may have happened in your childhood that you just didn't remember anymore. And fortunately, there are some pretty effective treatments out there. So we've been able to find a way. I actually almost stopped being a physician entirely because some of those things were pretty rough to deal with. But fortunately, we're still here. And I'm excited to help other people along the way. So my presentation is a bit more informal. I have some talking points that I'm referring to. So if you see me look off to the side, I'm just looking at some of my notes. But at any point, you can feel free to stop me and talk about anything, or share some thoughts, questions, or anything. So one of the first things that I wanted to talk about that I was invited to share is sort of how the healthcare community plays a role in suicide prevention and PTSD and trauma identification. So on the suicide side of things, one of the things that we focus on, nationally, we look at like diseases that cause, deaths in our society. And of course, it's probably not super surprising to know that the most common killer in the United States is heart disease. However, heart disease tends to affect people of an older population. You don't tend to see a lot of children or young adults with heart disease. You tend to see people in their 50s or later that are dying of heart disease. So, there's other ways that we can look at death and how that's impacted in our society. And one of the things that some population scientists looked at is what's called valued life loss. And so when you look at valued life loss, you just arbitrarily pick an older age. There's not really a significant number to aim for, just an age that's like, hey, once you've reached this age, we would say that if you died after that point, you have lived a full life. That's just what we would generally say. So that can sometimes be 75 or 80 years old. Of course, there are plenty of people who live happy lives beyond that point. But the way that these scientists look at it, if you are 80 years old and you die after that, you've generally lived a full life. So when you look at diseases that actually cause the most valued life loss in our society, so for example, if you said that your age for a full life is 80 years old, then if you died at 40, you would have 40 valued years of life lost. And when you look and see how many years we lose each year as a population of valued life, the number one thing that takes away the most years is suicide. And that's because, just like we heard in the previous presentation, it really does impact a lot of teenagers and young adults. It's one of the most important things that we're always taught is, whenever we even do our basic licensing exams, a very common question is, here's a teenager in your office, they're perfectly healthy. What thing do you always screen for? And depression is always one of them, and suicidality. And that's a pretty common question that you get asked whenever you go into any doctor's office. Sometimes it gets just brushed off very quickly because sometimes it's just like, it's gone through pretty quickly. Sometimes it's in paperwork that you do beforehand. But that's often something we do is we screen for that. And then if it's positive, then we can interact and try to do something to get involved. Sometimes that still can be really challenging because as depression and suicidality is associated with a lot of people who don't have resources, or people who have resources but family that just got supported. So it can be really, really challenging, especially when people are involved with are part of different minority groups. Like if they're there's a lot of queer youth that experience depression and suicidality, but maybe they don't have a family that really would support them with any of those things. Maybe there's a lot of youth that experience racism, and sometimes it can be really hard to really treat or escape from those things. So we can try to intervene and work with these individuals. There's a lot that you're working against to try to help these people. But that's one of the big things, is just screening patients. So that way we know everybody who comes and sees their regular doctor should get screened for depression. For PTSD, on the other hand, that one is actually, not a lot is known about pediatric PTSD. Not a lot is known about how it impacts kids. In fact, some of the things that we do now are actually some of the things that Dr. Holler already spoke about. It impacts their emotional development. We know that it makes them more emotionally reactive. So that means that as they age, so as what we would say a typical person as they age, someone who is raised in an environment with well emotionally regulated adults that can help them learn how to emotionally regulate themselves, would grow up and they would become less emotionally reactive as they get older. So the problems that they face as they get older will cause them to have less extreme emotions. But for kids with PTSD, kids who have been exposed to trauma, that's not always true. And as they get older, they actually become more reactive to stress and trauma. So things that aren't even legitimately causing a threat to their life at that moment is being experienced as this terrible life-changing event. And it's really hard because you're in this place, especially when you're treating people like that as adults, when they become adults, is validating them in their space and saying, yeah, this makes a lot of sense why this event, this thing that's happening seems life-changing and scary, and at the same time trying to orient people to understand that they are safe. This is why PTSD treatment is always under, there's a lot of research going on with it. But it is really important in children. There's a lot of PTSD. One of the things, like in the mid 1900s, there's a psychiatrist. His name was van der Kolk. I guess it's more closer to like the 60s or 70s. But he did a lot of work at the VA, and he noticed that there were a lot of soldiers when they came back from combat that were I think at the time they called it shell shocked, but that's not really a term we use anymore. I think we haven't used it for decades, but now we use the term PTSD. And so there's a lot of effort in being able to tell people that, PTSD is associated with the military and being exposed to combat environments. But now there are a lot of psychiatrists that are noticing, and other therapists and psychologists that are noticing that, no, it's not just this people group. We all actually get exposed to trauma all the time. And PTSD is a lot more common than we thought. And there's a lot of people who are neglecting it and experiencing very, very unpleasant lives because of it. Not to get too into the weeds of it, evolutionary biologists will look at mammals as a way, like if you look at your brain, we have like a lot of different sections to your brain. The higher up parts are like the most evolutionarily new parts of your brain, and then the deeper parts tend to be evolutionarily older. It's much more complex than this, and I am not an evolutionary biologist, but to put it in very simple terms, we have a progress where we have, reptiles that evolved generally into animals with feathers, and birds that generally evolved into mammals. And so our brains actually show evidence of that. We have parts of our brains that are very similar to reptilian brains, and we have parts of our brains that are very similar to avian brains, and then parts of brains that are very similar to other mammals. And the parts of the brain that are very reptilian supplies a fight or flight response. And the advent of mammalian evolution allows for this really, really beautiful system that lets us feel safe by socializing with other members of the same species. In fact, it's really funny when babies play peekaboo, when you play peekaboo with babies, that's actually a game that you can see in a lot of other mammals. A lot of mammals have their own version of peekaboo because it strengthens the part of your brain that allows you to switch between the stress state and a safety state. And when you experience trauma at a young age, which like 2/3 of our society have a significantly traumatic event while they're still a child. And when you experience all this trauma and you're not allowed to regulate yourself, and you're not in an environment that regulates yourself, it just makes you more reactive to it. It doesn't slow down. And then it sort of just builds on itself and makes it worse. But that kind of leads us to the question of just like, what things can we do to help kids that you may see that may have trauma, help kids that may be experiencing these things? And, this is a good point where I can bring up like trauma-informed care. If anybody wants to learn more about trauma-informed care, if you just Google it, there's like traumainformedcare.org that has a lot of teaching points, and I think there's even trainings for it if you want to. But one of the most important things that you can do is just provide a validating presence. Among these people that experience trauma, 60% of youth that experience trauma, one of the things that always comes up in these conversations, or that commonly comes up, is like, well, what about these people that experience trauma and it seems to propel them forward in life? And there are these people that experience trauma and it seems to just really weigh them down, and it causes them to spiral out and become more and more unhealthy and cause a lot of damage in their life. And one of the big things, and there's a lot of things that people propose, but one of the big common things is in the midst of their formative years and they're experiencing all this trauma, they have one person that they can turn to, one person that makes them feel safe. And oftentimes that person is a teacher or a coach or someone at school, or a librarian. That one's a common one too, because those are people that are able to ground them. I mean, I wouldn't be a doctor if it wasn't for my teachers. They were super impactful in my life and making me feel like I could do something when a lot of my environment at home or elsewhere in my life did not make me feel like that. And it can be really important and powerful. So making someone feel seen is a way that you can actually activate those parts of the mammalian brain that evolution has graced us with that allows us to downregulate the trauma and feel safe. And safety is like the paramount of the mammalian experience. Safety is really what a lot of us are after. You know, there's safety of self, where you're allowed to, you know, breathe and have access to water and food, and there's safety in shelter, and you have like a clean, warm place to live. There's safety in the community, where the way you express yourself and the way you experience culture is accepted and celebrated. And then beyond that, there's safety of self, where the feelings that you experience yourself are okay to have inside of yourself. And when you have PTSD, you rarely ever experience safety of self. You know, there's a lot of feelings of guilt. Guilt is a very prominent feeling of PTSD. Depression can come with PTSD. And even there's some data that's pointing to the fact that ADHD can be linked to PTSD. Just ADHD, a lot of kids can be hyperactive and not able to keep their attention in one place. And there's this thought that that can be beneficial in a traumatic environment, because in an environment where your trauma response is turned on, you're paying attention to a lot of different things. So because you're hyper aware and you're looking for dangers. It's just your brain does that subconsciously, and it can manifest as hyperactivity and poor attention span. But one of those things that can be really helpful in all of these situations is really just validation. And, you know, if someone complains or is sad or something, just saying that makes sense to me. Saying something like that makes sense to me is never going to convince someone of like continuing to do something. If someone is thinking about doing something very dangerous to themselves, if they're thinking of suicide or thinking of hurting themselves, you know, you don't have to leave the comment there, but saying to someone that, hey, your feelings make sense and they're not crazy. Because even down to the science of it, I mean, neurotransmitters don't come from nowhere. There's a reason they feel that way, and it makes sense. They're seeing something, they're perceiving a reality that's different than yours. And it's very scary, very harmful, and very damaging, but there's nothing morally wrong with them, you know? And a lot of times when people are in these states, they feel like there's something wrong with them, but just giving them a place of saying, hey, the way you're feeling makes sense to me, and I care about you, and I don't want you to feel alone or feel like you're a burden, or because there's not really a way to address the fear of not dying. But that's where like a lot of teachers can step in, because I'm sure you've heard this before, and I'm sure it's not new news that that you can really impact these students' lives. But validation is like a very important key, because it not only allows people to feel safe, but emotional validation is like a trigger in our brain that we are in a safe place. One of the things that we notice with PTSD is that our brain has a really does a really poor job at distinguishing between physical trauma and emotional trauma. So being rejected by someone you love can cause the same damage to your brain as being physically assaulted on the street. Because the way that our brains have evolved, social success is equivalent to physical success. So if you aren't around people who you're able to be socially successful with, they won't help you get food. They won't help keep you safe. They won't help you build a shelter. So our brains evolved in a place where I'm like, oh, these people don't like me. My body is going to make me feel so bad about that, because my evolutionary ancestors, if they weren't socially successful, they died. So the people who felt the worst about social failure were the most successful, because evolution doesn't typically care about how you feel. It just cares about keeping you alive. And that's how natural selection works. So in a way, we're kind of just involuntarily in these human bodies experiencing a lot of pain and suffering because some force of physics likes to keep us alive. But that doesn't stop us from having safe and happy and fulfilling lives. And so emotional validation can be a big key to step in to say, hey, the way you feel makes sense, and the way you feel matters, and I care about you. I don't know. I hope that helps. That's kind of one of those are kind of the talking points that I was going to go through. I apologize that it wasn't as organized. But if you all have any questions, I'm happy to answer them. Pediatric PTSD is really complicated and not a lot is known about it. It is really interesting. Yeah, I actually read a study that PTSD in children does increase Alzheimer's. It was funny that you also mentioned that experiencing, racism as a pediatric individual increases risk of Alzheimer's, but racism is also another form of very damaging trauma. So that makes sense.
It does.
Right. Thank you, Dr. Levy. I think if I could jump in real quick, yes, that idea that you were talking about, feeling like you belong, is very important, right? And so we can see how, racism is basically telling you that you do not belong to this society and this system, and how damaging that could be. Also, you brought up the idea of intersectionality between, the LGBTQ community, right? So if we think about if you're a gay Black male in an impoverished environment who's exposed to violence, I would think that that person is at risk and would need to, be screened for suicidality.
Yeah, it is very saddening to see, like, when you see people who experience racism because they're Black and the different health disparities they experience, and the people who are queer who experience different health disparities. And then when you're Black and also queer, it's like synergized to be an even more suffering experience. I mean, HIV is increased in queer communities and other people of low socioeconomics, like people who are in impoverished communities that are Black. And then if you see Black queer people, like Black trans people, 50% of them have HIV, and that's insane to me. Very sad. I see a question, how can it be diagnosed in teenage children? So that is actually a pretty complicated question. I am not a fellowship trained child psychiatrist, so maybe Dr. Haller might have a better idea, but there are guidelines for it. I mean, when it's diagnosed in adults, there's like a checklist you need to fit. There's like 3 different categories of like hypervigilance, and you need to meet a certain number of symptoms in those. And like, we have all these things to like diagnose it, but in humans, a lot of these things don't fit into boxes. So a lot of times, especially with these newer diagnoses, I mean, there was one person was going to change, the DSM-5 is a manual that we use to diagnose all psychiatric conditions in people. And it is always changing. A few versions ago, homosexuality was a disease in the DSM, but it's not been in there for decades, but it is always changing. And they noticed that if they did change the diagnosis of PTSD to include childhood trauma explicitly, it was like the prevalence of PTSD went up to something crazy, like 80% or something like that of society, because so many of us experience childhood trauma. So it can be really challenging, but one of the big things is hypervigilance and flashbacks. So if you have a traumatic event that months later, I think greater than 6 months, if you think about that traumatic event or are reminded of that traumatic event, and suddenly you become very hypervigilant and you experience feelings that you are in that moment again, that's pretty cut, clean, and dry, regardless of what age you are, that would be PTSD. But it's harder to identify. I mean, in teenagers have a better idea of who they are as a person, but in children who are younger than teenage years, sometimes you don't see that, except for in, like, if they're playing, they may role play a traumatic event. I mean, there are kids that you can see if they have a doll or a toy or an action figure that they play with, like, kids will oftentimes, act like that thing is their child. And if you see them, talk really rude to that thing, or like abuse that thing, that can be a red flag that maybe that's how they are also being treated or were treated at that age when they were younger. So that can be one thing. Or if kids experience like something else, like a car accident, sometimes they'll role play that. And then of course, one of the things that I think is a bit more well shared and well described is, of course, if you see any kid mimicking like a sexual act that they wouldn't know about, that of course can be indicative of sexual trauma. But yeah, it can actually be pretty hard to diagnose in kids, especially since some people, a lot of personality and long-term disabilities, it's like this age of 18, they say that's when your personality is permanent. And like, there are a lot of people who are saying that that's not really true anymore. So sometimes it's a bit more complicated, but generally that hypervigilance and flashbacks 6 months afterwards, once that can be identified by a specialist, is generally what it is. That was a long-winded answer. Hope that was.
If I can add, Dr. Levi, if I can add, so for diagnosing in children and teenagers, what you would look for post-traumatic stress disorder, they would have to have had some kind of event in their life where their life was threatened, right? So being in a car accident, living in an environment where there was some severe storm or hurricane, tornado, your home was destroyed, being exposed to violence directly, or observing it, being close in the vicinity of violence. Those are things that lead to the onset of PTSD, and the hypervigilance, that might be seen as jumpiness in children, having a high startle reflex, blinking a lot, being startled very easily. And often, these lead to problems with sleep, and then you'll see depression. And in children, depression, often looks like aggression, right? And it can be misdiagnosed. Children tend to not have the brain's not developed yet to have all of the cognitive things that go on with depression that you would be able to see manifested in adults. With children, we look at violence. So, violent behavior, hypervigilance, increased startle response, difficulty sleeping, and, feeling like you don't belong, not having friends, being isolated and alone. Those are people that I think we need to keep our eye on and try to pull them in.
So I just had a quick question, because I know we're talking about signs of suicide, and we're talking about post-traumatic stress. How I guess do those diagnoses, or I don't know, I'm saying symptoms, but I don't think symptoms is the correct word. So as an educator working with students where you see some of these things, what resources are we at that point? Are we looking to see if they're suicidal? Because there's been some research that says that when students are polled, that they're exposed to stress. So there's a high incident of PTSD within our school system. Undiagnosed, untreated, unrecognized. Is that like a is that like the next step to that suicidal ideations? And how do we, what do we offer them? Because I understand to the point that was made, the connecting with them, acknowledging them, their whatever they're going through. But what's the next step, I guess, for us? Question.
Well, for PTSD, and the individual would have to get involved in some type of psychotherapy, like exposure response prevention, dialectical behavioral therapy, DBT, teaching mindfulness, how to be aware of what's going on inside of your body and in your mind in the moment, and how to, teach them how to reduce stress. So it's not something that I would say that we could treat without sending the individual to get professional help. There are also some medications for anxiety and things that might be prescribed as well. And so I would recommend that they, first of all, go to see a physician and make sure that there's no, medical illness, physical illness that they're experiencing, and let the physician refer them to a psychologist or psychiatrist. Because if you go to a psychotherapist first, they're going to see what their expertise are. They're not going to necessarily see that you may have some type of medical issue going on that looks like these other psychological illnesses.
All right, Dr. Wright asked a question in the chat, And she can speak to it on her own, but it's stated in your practice what impact, if any, that social media had, and I guess pros and cons of social media on suicide. So Dr. Wright, if you want to elaborate.
Yeah, I'm just seeing the impact of students having social groups that they operate within, and sometimes the impressions they get from those groups about themselves impact them greatly, and that comes through their phones, or if they have technology that they're sharing together, and it seems to have intensified things. So at one point, in seeing students who were coming to counseling, you sit with them, the two of them, and you may be able to remediate, or a group of girls or a group of little boys. But now it's spreading all the way into the home and overnight and over the weekends, where this sense of being put out of the group or not accepted and shunned has a great impact on our students. And so I've heard many of them behind incidents like this say that they want to harm themselves. And so we've had to address that in many different ways, but just wondering what the doctors are seeing in their practice, if anything.
Sure. Well, I can talk about research. There is research out there that says that when there are these traumatic, violent events that you witness on social media, that is damaging to your mental well-being. So the George Floyd murder, public lynching that was broadcasted all throughout the world, repeated watching of violent experiences like that, it almost it can lead to this vicarious type of traumatization in individuals. So I wouldn't recommend, people expose themselves to those things on social media. If you notice, that's why you see now they cover the videos and let you know that this is going to show you violence, and you have to click it in order to, to consent to seeing the violence, because, it's just as damaging, as being there witnessing it live.
And it's like live and in color and repeated. So I think, yeah, and I do know that, and well, I don't know, but my assumption will be that there'll be a lot of studies, a lot of research, after we get to the other side of the COVID pandemic, the isolation that it caused and the level of stress and trauma. But yeah, I'm sure we'll get more information to come. So I don't know if there are any other questions. We're almost at the end of our time.
There's a question, Kathy wrote, there's been a spike in suicide of elementary school children. How do we identify and address suicidal children? Again, you're not going to be suicidal without the depression, right? So depression looks like not sleeping or sleeping too much, not eating or eating too much. But typically you're going to start to notice mental health problems in the person's sleeping patterns. So look at if they're getting enough sleep. You have to query at home and find out what's going on at home. Again, I said that children, when they're depressed, it's expressed as anger, aggression, or violence. And oftentimes that may be misdiagnosed as some type of like conduct disorder or oppositional defiant disorder, but they might be depressed. They're just very young, and that's how it's expressed. And so I guess if you notice these things in children, a significant drop in their grades all of a sudden, the inability to sit still in their class, they're not sleeping, so they're coming to class and they're falling asleep in class a lot, or they're being aggressive or overly emotionally reactive to small occurrences, those are kind of red flags that, maybe the child should be screened, or the parent should be consulted about the child's behavior. So it's going to be something in their behavior that you're going to see more so than them talking about the complex thoughts and ideas that they have about themselves and life and their relation to those things.
Another quick question, Dr. Haller and Dr. Levy. We talked about the need for treatment, and we know between the stigma of mental health treatment, mental health in general, and the real lack of investment by our country and institutions to address mental health issues, is there any value in group impact, group programs in terms of cognitive behavior? What can we do? And of course, we're not trying to quote cheat anyone of having that individual opportunity, but are there opportunities to work in groups and in families? Does it help to normalize the importance of articulating and seeking treatment? Can it be effective?
Yeah, I definitely think we have to normalize it, and we kind of are. If you look at the country as a whole, you see a lot more people talking about mental health problems. You know, I think the Olympics had a lot to do with that, seeing our athletes come out and report that they have mental health issues. I mean, that's why we use athletes to market products, because people will grab hold of those ideas. And so when these athletes started coming out talking about their mental health issues, we started to see people being more willing to do that, especially in the Black community. So I teach at an HBCU, and now I often hear of situations where students are reporting that they've been involuntarily committed, had a psychiatric hold, or they're reporting issues with their mental health that I wasn't hearing earlier on, maybe 10 years ago. We also see that the exposure to violence, I think, is very important, right? So when I was teaching at a PWI, a predominantly white institution, none of my students ever came to me and told me things like, I was shot over the weekend, or my friend was shot. But at an HBCU, at least once a year, I have experienced something like that, unfortunately. Case in point, this semester, a student was shot by a stray bullet at a basketball park at night. And so this was amazing to me that, not only do they have to deal with college and that type of a life, but there's also the violence that's going on at the college level that they're exposed to. So, I think normalizing it, talking about it in groups, allowing people to be open, creating safe spaces where people can talk about their mental health issues without the fear that they're going to be, hospitalized or put on some type of psychiatric hold. I think if we can normalize just talking about it in general and in the elementary schools especially, that would be helpful. I think that, you should be taking psychology classes in elementary school. You should learn how your brain works and your emotions and your behavior and how all that's connected, and how you can control your thoughts by controlling your emotions or changing your behavior. That needs to be taught at a younger age than, when you get to maybe high school or your freshman year in college. At that point, that's kind of too late to try to teach someone how the brain and their body and behavior work.
And I think in some school systems, to that point, that they're, most of what you think about is discipline, and that kid has to be, penalized or punished for that behavior. And what I'm seeing is that they're more, we're moving more towards restorative practices and considering that. And I know there was a mention of trauma-informed pedagogy, which are things that are like in the periphery, and hopefully we can mainstream it in our schools, because again, a lot of it is like, that kid did something, I want to see that kid punished, and that's from the adults. So we're gonna need to, and that's the goal of these forums, we're gonna need to change some adult mindsets to make sure that we're actually addressing, some of the things that our students are experiencing, because we're just thinking, this kid is acting up with me right now. How can I get this kid out of my face? And that's not always what we need to do. So
right. I had a case where a military family had a child, an African-American female. I think she was about 13 years old or 14. And she was reporting experiences of racism at school. She's a military kid in upstate New York. She's one of the only Black persons in the school. People were picking at her on the bus, talking about her hair, her nose, her culture, saying Black people haven't contributed to society, only Asians and white people have. And so she ended up writing an email talking about she wished she was dead, and it got flagged because she wrote it at school on the school computer system. And they brought the child into the office. And when she told them about the racism she was feeling, that's why she wrote that, you know, the person she was talking to at the school said, "Are you sure that it's racism?" You know, so the girl didn't feel heard. She didn't feel like she belonged. And so what Dr. Levi was saying is that to validate the person is very important. And so, you know, that, you know, the parents, you know, brought me in to kind of consult and see what was going on and what could be done, and, you know, what kind of services the school should be providing since this occurred in
Out
the
of
school
that.
environment. Yes. And so,
My goodness.
oh,
My goodness.
I think someone's
Yeah.
mic is something on, sorry.
So yeah, so I definitely think it's important to validate what our students are saying from their perspective. You know, you got to meet them where they are and then walk them to where you want them to be.
One of the really important things that I think Dr. Holler already mentioned that is actually very helpful for PTSD and relatively every mental health disease is dialectical behavioral skills therapy, which is very fascinating. It was actually developed by a lady who had borderline personality disorder when there was no treatment for borderline personality disorder. And still to this day, it is one of the most effective treatments for borderline personality disorder. So she essentially just made her own treatment, and it's one of the best treatments we have for like a lot of different mental health disorders, which is a pretty cool background on it. But one of the really important things of dialectical behavioral skills therapy is understanding that everyone's feelings make sense. And that's where like validation comes from, and it sort of separates validation from agreeing with. So if somebody says, "I feel this way, I want to do this damaging thing," you can say, "Hey, it makes sense why you'd want to do that." That's different than agreeing. Agreeing would be like, "Yeah, you should do that. That's a good idea." And those are two different things. And it can be really hard to just take a step back in validating, especially like, I mean, I am not a perfect individual. I've run into people, you know, that I've made to feel uncomfortable. It's really hard to, when someone says, "Hey, you made me feel this way," to say, "Oh yeah, that makes sense," because you don't want to be a person that made someone feel that way. But yeah, that's super important to be able to identify these kids and also be someone that they will tell when something is wrong, is someone that their feelings are safe with. And if they don't feel like their feelings are safe, they won't say anything. They'll just shut down or avoid the conversation.
I know our
Right.
time is short. Thank you so much. One other question, just very quickly, is about bullying. We can't talk about suicide without, or maybe I want to ask, just how do we address, and if bullying is such a huge issue, very difficult to get your hands around it, I know, as a teacher, etc. But it seems like one piece that has come out is this idea of validating. What else can we do immediately or in the short term, in the simplistic way, in our schools to address bullying and its impact on the mental health of our young people? And then, did the school to prison pipeline, Dr. Holler, did that alienate our Black youth and make them, does that have any parts of what we're seeing with our Black males in school
Right,
and their health?
Right. That's a very good question and a very, very big question to answer. I think that relates to the thwarted belongingness for young Black males, right? Not being able to integrate into society. Where are the social programs for young Black males, right? Where are those community centers that used to be active, community organizations? I don't see too much of them going on today. Where are the social programs for young Black males, right? So, you know, jail or prison is not a social program for Black males. And so that just leads to further isolation of the individual, where they feel like they don't belong and now they feel ineffective. They got this criminal history. Going back to talking about what we can do as far as, you know, belonging in groups, there is the National Alliance on Mental Illness. That is a group that you can use as a resource to reach out to talk about what's going on that you're noticing in maybe your schools, maybe begin a partnership with NAMI, N-A-M-I, National Alliance on Mental Illness. I know when I was in Chicago, I reached out to them and they came and participated in some of our workshops. as well. So what we want to do about bullying, though, we need to increase belongingness, make people feel like they belong, like they're needed, because the need to belong is a fundamental human need. And if it's not met, that damages your well-being. Dr. Levi was talking about that. I talked about that earlier, and about how structural racism makes people feel like they don't belong. But so you have to include programs and groups and get people associated with some type of a group where they feel effective and they feel like they belong. And then, you know, to address those issues about violence and bullying, you got to kind of have like a zero tolerance policy on bullying. And that includes social media bullying as well. You know, not that we want to be so punitive again to find another reason to kick children out of school or to arrest them, right? But the culture, maybe have an assembly to let people know, like, hey, we're all a family when we're here at this institution, and we're not going to tolerate any bullying because everybody belongs here.
And I just a quick one. So is it still, because you know, when I think about bullying, I always think about the saying that hurt people hurt people. So how do we, you know, how do we address the bully? You know, because we know that their actions or their words or their behaviors are negatively impacting, you know, their victim. But at some point, my thoughts are they were also victimized and it was not fully addressed. So yeah, there's a lot now. Yeah, that's
Yeah.
my thought. So I guess I'm one of those teachers. I almost side with the bully because I'm trying to figure out what the heck. Why are you, you know, expressing your whatever and in an aggressive way that you're, you know, you're harming someone else. So yeah, but anyway. So that's
I agree. I agree that counseling would be something that probably should be recommended or referred, because people aren't just naturally aggressive and violent toward each other as children. It's a reflection of something larger going on in their life, maybe at home.
all right. And I appreciate you both so much. We've gotten so much valuable information that I want to share, and hopefully the rest of you guys do too. We can take, we are over time, but if there are any closing questions, remarks or anything, and then so if either of you want to make closing remarks, if there's nothing in the chat. So last call for questions.
I just put in the chat that if you want to reach me, you can reach me at hollerd@cookman.edu. The email's in the chat, and I can send you some copies of the slides.
That'll be great. All right, and if either of you guys would like to make closing remarks, we'd appreciate them. And if not, that's fine too, because you guys can share so much good information.
There's a question, Stephanie Collins.
Okay, go ahead.
It's not so much a question, it's I just think that I'm sorry that I was late. I had another Zoom, but this is such wonderful information. And I'm dealing with some family members that have some deep-seated issues, and I'm kind of at my wit's end. So I just found listening to what you were saying to be very helpful.
Thank you.
I just
Alrighty,
want to say on that note very quickly, Dr. Holler, well, this sounds silly, but you are my hero. Not just because of your involvement in this work, but your generosity, your kindness. And I really, really appreciate it. It has meant so much. And it's just it's been very profound to also see someone who really can connect the history of Black people to these issues that we face. And I just want to thank you so very much. And Dr. Levy, I really appreciate your transparency and your humanity and your involvement, and as well, Alyssa with CIR, who helped make that happen, the Committee on Interns and Residents. And this is about us connecting together. And I'll shut up after this, but we see workplace health issues amongst healthcare workers that we need to connect and doctors and nurses, higher risk of suicide, teachers now under deep trauma. And I hope that these opportunities will give us a chance to come together and work together across fields and cross sector. I hope you reach out to Dr. Holler and hopefully invite him to other programs and events. And Dr. Levy, we're here for you and University of Illinois in every way.
Thank you, and
Yes,
thank you, Ashanti, for
thank
bringing
you.
us together. We have Kathy Dell, who's here, Bertha Purnell, who's here, Dr. Wright, Dr. Ruiz. There are a number of people that are part of the Chicago School Network that have come together to schedule these events. We have on our schedule another one in January 10th. Bertha and Mary will be facilitating the grief and healing process. Because again, we are mainly focusing on school-based issues, but we have community members who've also experienced death and trauma that we will be focusing on at our January forum. So again, thank you everyone who's attended. We will make sure that you are kept posted on any upcoming events. Again, we do have one scheduled for January, but we do plan to come back together and host other forums. So that's it for us tonight. Thank you for your attendance and thank you for participation. Bye.
Thank you.
For a
Thank
wonderful
you, everyone,
forum.
for joining. Tammy, that was really great, wasn't it?
It was good.
It's
That was
it's
good.
recording. I see the
Okay.
the red dot there, so I'll work on that tomorrow.
All right, great. And can you share it as soon as you get a chance, please?
Yep,
'Cause
absolutely.
We're
I might need help from my grandson to make sure I get it done right. So
All right.
well,
Yeah,
but we'll be on it in
I
the morning.
understand.
And get it to you
All right.
tomorrow.
That'll be great. And
Thank
then
you. You did an
yeah,
excellent
I'd like
job
to
as,
share it.
as
Thank
host.
you. All right, thanks, Margot. Margot and Pat Bowden and Stephanie are part of the Black Caucus. They're on our steering. I don't know if you recall them all when you were you came to visit with us. But thank
Oh,
you guys for
that's
attending.
wonderful. That's great. So great
All
to
right.
see you all and join together in this conversation.
All right,
Thank you so
Shanti,
much,
thank you so
Tammy.
much. And yeah, well, I know we'll be talking later this week, so I'll see you soon.
Okay.
All right, bye-bye.
Okay. Bye-bye, everybody.
Bye.
Hey, that was really good, wasn't it?